here is breast cancer, because this is what month?
Breast cancer
awareness month.
That's right.
What do you know about it? So we've got some little questions and a bunch of slides for you today. This just tells you who we are again. And this is what we're going to talk about. What is cancer? What are your risk factors?
Breast cancer facts and figures, signs and symptoms.
Prevention, self-breast exam, early detection, and some treatment. So guys, what is cancer?
Cancer in general, what is it?
cells gone haywire.
Well, that's true.
That's exactly right.
That is the truth. I like to think of them as Teenage Mutant Ninja Turtles. Who's heard of those things before?
And I like to think of it as cells gone wild, so Jackie and I think alike.
So this is kind of the definition, and cancer is a group of diseases with the following characteristics. Abnormal cell structure,
Uncontrolled growth,
ability to spread,
and ability to invade other tissues, so they can get out into your bloodstream and go to other areas of your body, different areas from where it started.
So that's what makes cancer cells different from normal cells, because normal cells don't keep growing, do they? That's why your eye tissue stays in your eyes, right? So it doesn't keep getting bigger and bigger, because cancer cells do what? Does it stop? No, not until we do something about it, okay?
And when they get into your bloodstream, like a breast cancer cell can get into your bloodstream and go to your lung, your brain, your bone. So that's why it's important to catch it early.
And cancer cells also do something kind of wild and crazy, and they're kind of mutated. What they do is they create an enzyme, break down cell walls, and invade the tissue. And that's how they get out and get into the bloodstream, unlike normal cells that are floating through the bloodstream. Okay, so we got some facts and figures now that you know about those crazy cells we call cancer. So what are some facts and figures from the United States?
It's pretty high. It's 232,670 as of this year. And about 5 years ago, it was about 170,000, so it's gone up. But we don't know if it's gone up because more women are getting screenings and they're finding more cancers, or if it's just gone up because there is more cancer.
So the estimated number of deaths is about 40,000 women per year. And these are statistics from the American Cancer Society.
In North Carolina, the incidence is 5,870 and the estimated deaths is 1,090.
Now look, we made a boo-boo. Do you see what we did?
2004.
Well, that is from 2004. That is true. That part's true. The average diagnosing one case a year? No, that's not true.
We wish.
It's about 150. We did not see that, Luke. It's about 150 new cases in Alamance County a year. That's a significant number because our county is not the largest county in the state.
And this year, we've already diagnosed about 154 breast cancers starting from January, so we've already met that number this year.
So we'll be well over that this year. So we've got a question for you, ladies. Do you know your risk factors? Oh, she should get a prize for that.
Yep. You want another pair of
She said obesity. That is a risk factor for breast cancer.
Anybody else?
Hang on. We'll do it.
Go back.
Smoking. Family history.
Heredity.
Heredity. Age. Y'all are smart.
And there's a difference between family history and heredity, but we'll go over that in a minute.
Being a girl.
Yay!
Yay!
Number one risk factor, yes! You get the prize, that is your number one. Alright, y'all are awesome. What, the
Your genes, that's
Your
exactly
genes,
right.
Exactly. So let's look at those again. Y'all are smart. About 85%, we said age. As we get older, what happens to us? Everything. Everything happens. But it's because the older we get, we're exposed to more things. So about 85% of all women diagnosed are older than the age of 50.
And being female is a risk factor, but can men get breast cancer?
Yes.
Exactly right. It's a small percentage, but they can get breast cancer.
Personal or family history of breast cancer puts you at higher risk.
And then genetic, about 10% of breast cancers are passed down genetically, and about 25% are family history. So
I'm sure you guys have, who's heard of the BRCA gene, BRCA1 and BRCA2? And we have a genetics nurse here at the Cancer Center, Laura Shapansky, who if you have a family history of breast cancer and you'd like to talk to somebody, we have a nurse here who will sit down with you, go over everything and see if you would be a candidate for genetic testing.
So the next one is early onset of menses or late menopause too. And the reason that is a risk factor is your body's exposed to longer periods of hormonal changes. So it's not really a risk factor that you started your period early, but it's just that longer period of time that your body's gone through hormonal changes.
What's early? Yeah, how early is early?
Early, like 12, 11, 12,
That's early.
yeah. Or if you have late menopause, like late 50s.
Earlier than that now.
I know.
They're going
Yeah.
pretty early.
Yeah.
But late menopause.
But it's that whole long period together, not just the early menses, but the late menopause too. So if they start their menstrual cycle early and then have late menopause, then their body's gone through changes for a long.
They say, yeah, that's
Yeah.
but, unless you're taking hormone replacement therapy, and some certain things, there's been some studies done that if you take progesterone and estrogens, it does increase your risk factors. So you can talk to your physicians about that too. Good question. Obesity, which most people don't even think about obesity. It's a risk factor for many, many, many chronic diseases.
Yeah, and if your waistline is larger than 35 inches, particularly after menopause, that is a risk factor and a concern.
Yeah. Oh, boy.
We were going to be mean to you and make you measure your waistline while you were here, but we decided not to do that.
That's not very nice to do while you're eating lunch, is it? Other risk factors are eating a high-fat diet. I just said hormone replacement therapy.
The birth of your first child after the age of 30, so late childbirth.
And drinking alcohol and smoking also puts you at risk. And then there's a new risk factor that's out. Who's heard of?
Breast density. This year, the state of North Carolina passed a law that if your mammogram reports that your breast tissue is dense, and that's just how the x-ray passes through your breast tissue, you may need other testing besides a mammogram.
And you will get a letter when you get your mammogram done. It will tell you that your breasts are dense and you're at higher risk for developing breast cancer.
And again, that's a small percentage, but
Now, is this breast density when you're younger? Because I know a lot of younger women have
Dense
denser
breasts.
or.
the dense breast tissue is fibrous tissue and connective tissue, because our breasts are made up of fatty tissue, fibrous tissue, and connective tissue. And the more fibrous or connective tissue you have in your breast, the more dense your breast tissue is. So we think of it as younger women, and then a lot of as you age.
But you can have, older women can have dense breasts. Older. But the reason we don't do mammograms on 20-year-olds is pretty much because they do have dense breast tissue. As we get older, sometimes the breast tissue changes and becomes more fatty replaced, but not everybody's. So if you're older and you still have dense breasts, you're at a little higher risk for developing breast cancer.
We'll show you
We're
some
going to show you
pictures.
some images of some mammograms. So y'all are great. You know your risk. So you know there are some things we can control, and there's some things we cannot control, right?
Who can control their age?
As hard as we try, we cannot control that, can we? So the things we can control is healthy diets, right? Not minimal, no smoking, little alcohol, good healthy weight. Some of those things we can control. We cannot control our genes or our family history, can we?
If you walk 1 to 2 miles a week, and that's a week, so that decreases your risk of breast cancer by 18%. So, yep.
So exercise is key.
Mm-hmm.
And we're going to talk to you about an event we're having for some exercise. Yes.
No, it decreases by 18%. Yeah.
Is there any other evidence that's shown if you exercise more than that, which I don't, but maybe other people do, that it decreases it by even more, or no?
Yes, I would think so, yeah.
Okay, y'all are doing great. All right, so we just said, what can we do? We just named those. There are also for people who are very high risk for developing breast cancer, maybe you had a biopsy and it didn't show cancer, but it showed some kind of really changes in those cell tissues. Sometimes those women can be put on a drug that we use for breast cancer patients called tamoxifen or raloxifene. And that would be a prevention thing. So that would be something we could do to change our risk factors. All right, so we know what our risks are. What do we look for? What are some signs and symptoms?
Take that one back.
Oh, hang on.
Don't let them cheat.
All right, so what do we look for when we're talking about breast cancer and you're looking at your own body? What do you need to know? Shape of the breast. Changes in the shape of the breast. Changes, color, discharge.
Dimpling
Exactly.
of the skin.
That's right.
That's right.
Anything else?
A lump,
Yeah.
A lump, yeah.
right? Sometimes you can even see a lump. You can feel it, but you can feel it. Redness. Exactly. Okay, y'all are good. Let's go and we're gonna look at our,
Make sure we got everything.
okay, sometimes we can't see it ourselves, and that's why we do what? The mammogram. Because that's where we can find the earliest signs may only be seen on a mammogram.
Sometimes you might have redness or a thickening of the skin, which is a peau d'orange. And sometimes that's a sign of a breast cancer that affects mostly young women, but it's very aggressive because the cancer gets in your lymphatic system of your skin and spreads very quickly. So if you ever have any signs and symptoms of infection in your breast, go to your doctor. They may try antibiotics, but if the antibiotics don't work within a 2-week period, make sure they do a skin biopsy, because that is called inflammatory breast cancer. It's very aggressive.
So some of those other changes you're looking for is dimpling, like we said, that's a breast indent, pucker, dimple, nipple pain or scaly, dry, flaky skin on the nipples that won't go away. You know, we all get a little dry skin now and then, but that dry, itchy, flaky skin on the nipples can be a sign of a cancer called Paget's disease.
And nipple discharge. There are some normal discharges, but if you have a clear discharge or a bloody discharge, that would be something you'd want to report to your doctor right away.
And change in the shape, we talked about changing in the shape. And some people do present with breast pain, but they say only about 10% of women with breast pain is a sign of a cancer. But we have lots and lots of women who have breast pain for multiple reasons. You know, menstrual cycles, there's all kinds of reasons we have breast pain. So breast pain does need to be evaluated by your physician.
But if it's targeted, if it's in one spot, not both breasts, but just one spot, that could be a concern. Otherwise, if it's bilateral, it's symmetrical pain, then it's probably hormonal or something just going on in your body. Sometimes premenopausal, or if you're pregnant, or things like that can cause breast tenderness.
Even chronic back pain can cause breast pain on one side because of those dermatomes that come around to the front of the chest. So some women have breast pain. That's why I said you have to talk to your physician because there needs to be a really good assessment of the pain. Okay. Do you guys have any questions about what to look for? It's important to look at yourself in the mirror.
Because a lot of these things you can't feel, and a lot of women do not look at their breasts in the mirror, but once a month, just when you get out of the shower, just look at your breasts in the mirror, because there are some things like redness, changes in the shape of your breast, or retraction of the nipple that you couldn't feel, but you could see in the mirror.
And unless you're born with inverted nipples, it's not normal for one of the nipples to begin to invert in. That can be something that's pulling in on the breast tissue, making it change its shape. Okay. All right, so what can you do? Let me go back. So what do you do about it? What can we do?
It's like that. So our thing is early detection is your best protection not just with breast cancer, but with any cancer, it's a lot easier to treat a cancer when you find it early. So what can you do?
So we're gonna make y'all say that with us, okay? Early detection is your best protection, because that is the truth. Is breast cancer curable? Yes, in its early stages, yes, breast cancer is curable. So that's when we want to find something, okay? So that's why all these things are so important. So what do? Monthly exam.
That's right. Have an annual breast exam with your clinician, your doctor, your nurse practitioner.
And the old dreaded mammogram.
And the mammogram.
The dreaded mammogram.
So what age do you start getting a mammogram? 40. What if your mother had breast cancer at 40?
35.
30.
10 years prior.
10 years prior to your mother's diagnosis, or your sister, your mom or your sister.
And we actually say that you can have a baseline mammogram at 35, so that when you're 40 and you go back for your annual mammograms, your doctor has something to compare that to.
So they're looking at really your family history. The American Cancer Society kind of says the age of 40, but you really need to know your family history, and if anybody has been diagnosed with a BRCA mutation, a genetic mutation.
So if you get that report from your mammogram and it says you do have dense breast tissue, there are a couple of new tests that we do not have 3D mammography and MRI here yet, but we are getting it very soon. But these two tests can pick up smaller lumps.
Harder to detect lumps,
Harder to detect.
they're more sensitive, so we will be getting those. Okay, right now insurance does not pay for 3D mammography
As
as a
standard
screening tool, but we will be getting that. There may be an additional charge.
And some places will charge, you may have to pay $50 above what your normal mammogram is if you want the 3D mammography. And I'm not sure about the MRI.
Okay, these are some images, and that we think they're interesting because some of them are this kind of shows some dense breast. See how all the white? That's what a dense breast looks like.
So that's why it's hard for the radiologist to see anything, because it just looks like snowstorm. Looking for a golf ball in a snowstorm. So
And we're going to show you something that actually has some cancers too. That's another dense breast. Dense breast.
dense breast.
All right, now that's a fatty breast. Do you see it's all gray looking instead of white?
It's pretty clear. They can pick
So
up
you
something.
could see something in there, couldn't you? All right, now this one, if you can, I don't know that you can see the little marker. Can you see the little triangle there? That means when you go to a mammogram and you can feel something, they'll put a little triangle marker over the area that you can feel something. And this doesn't have the little thing, but right below that is a dark white spot. Can you see that?
Sometimes they'll put markers if you have moles or other
Scars.
Yeah.
Yeah.
What about the markers from biopsy?
That from the scar, they'll mark the scar area.
Or they'll leave the little titanium
Oh,
clip.
that's a titanium clip. We don't have any pictures of those, but
It's tiny. It looks like a grain of rice.
I think there's another triangle. I can't see that. Is there a triangle?
Yeah,
there?
there's a
Okay.
triangle. I can't see it.
Okay. Now this is if you've ever been called back for a additional imaging. They magnify it up and they kind of compress you a little tighter. And it magnifies that area. There's a little marker. And again, they're looking at that dark white area. And some of these right here that I'm showing you are cancers, is a cancer of
And you
the
can
breast.
tell by this, they
See
call
how
it a
white?
spiculated mass. It has like tentacles going out from it.
And there's another one. Somebody could feel that one, and it does show up on the mammogram. And there's another one again. Now this is what
This
3D.
is showing the difference between 2D and 3D. And it takes sliced images, almost like a CAT scan, so that they can find something that's much smaller. It's easier for them to visualize, so you can see the difference.
Can y'all see the difference in that? We thought that we pulled some of this off the internet.
Some of them, because this looks like all the same thing, but then if you have this slide, you can see that it is different.
So are those tentacles indicating that it's spreading, or?
It's just probably a cancer.
It's just showing it's probably a cancer. Now, how do we know for sure it's a cancer? Right.
Biopsy is the only definitive way you can tell whether something's a cancer or not.
What are your chances if you, or maybe you can't say what the chances are, but if you had previous cancers throughout your body?
It
Does
does
that
increase
increase
your
It
your
risk.
increases your risk of
Mhm.
developing a breast
It does.
cancer. It does. And this is just kind of what, I think this was the breast MRI. You lay on the thing and kind of go through the machine there. You're laying it face down.
I've been waiting for that for mammograms forever.
So how do we put the puzzle together? How do we diagnose breast cancer?
And somebody just said,
Biopsy.
That's right.
And there's different ways to do a biopsy. So as you talk to women who have been diagnosed with the cancer, they may say, well, I had mine this way, and I had a biopsy done this way. That's because there's multiple ways to do a biopsy.
And they try to do the least invasive type of biopsy, but they need to get a certain amount of tissue for the pathologist to look at. So the radiologist and the surgeon have to decide which type of biopsy is best for a patient.
Do you do all these biopsies here in Kansas City?
We don't do the MRI guided biopsy yet.
But
Yet.
everything else?
Everything else we do.
And
We
they-
do them here in the breast
Up
center.
in Norval Breast Care Center.
All right, so once a woman's diagnosed, then what happens? Then we've got to figure out a treatment plan, right? So we get the biopsy, now you know you have cancer, now what?
Come to cancer center.
We can come to the cancer
Yes.
center, that's right. So there's lots and lots of treatment options. You may get,
You may have surgery. There are different types of breast cancer, and so what your treatment depends on what your pathology shows. So some women may get surgery, some women may get chemotherapy, and some women may not. Usually women do get surgery, some type of surgery. Radiation therapy may be an option, but it may not if you've had a mastectomy, anti-hormonal therapy and targeted therapy. So it just
Yeah.
depends on what your pathology showed.
do you know what targeted therapy is?
No.
No.
Aimed it directly at the cancer.
Yes, it does. It aims it directly at the cancer. I think we have a slide on one of the drugs, and we'll tell you a little bit more about that. But you don't get the same side effects as you do with the regular chemotherapy. Okay, so surgical, we're just gonna kind of scan through these, okay? Different types of surgeries, and everybody is an individual, and so
You have choices.
you have choices.
They do recommend that they do the least invasive surgery also if they can. But some women need mastectomies, but some women, they're able to do a lumpectomy with radiation now to get the same result.
Then there's just been some studies that we've been hearing about, that there's proof now that doing the lumpectomy, okay, the least invasive, just taking the lump out, is really a better survival rate than
And more
mastectomy.
beneficial.
And more beneficial to the woman.
Mhm.
If you can do that. Now, everybody doesn't have that option and everybody can't do that, but there are studies coming out. You can talk to your surgeons and your oncologists about those. You also check that, we call it the sentinel node. They check with the lymph nodes under the arm, and the sentinel node may be the first lymph node that a cancer would have gone to. So they'll check those lymph nodes.
Sometimes you would need to see a plastic surgeon, but there's something called oncoplastic surgery where they can leave the outer skin intact and take out the cancer, take out the breast tissue that they need to take out, and it leaves better cosmetic results. This is fairly new, but Sheena and I have seen some wonderful things. We go to a conference every year, and they have shown some wonderful results where you don't have to, if you needed a mastectomy, but they can do it without removing the breast and leave the tissue and the nipple sparing, and just take out the cancer tissue underneath the skin. It's really amazing.
And I think a couple of our surgeons are working with some of our plastic surgeons now and doing some oncoplastic surgery. And then, of course, if you do have mastectomy, reconstruction is an option. And there is a law that states if you have a mastectomy for breast cancer, by law, your insurance has to provide reconstructive surgery.
And we've had a couple of patients that even had a lumpectomy, but it didn't leave their breast looking so good, so they did have reconstruction on a lumpectomy site.
And we're going to kind of jump through this really fast. You and your doctor will talk about if you have a lumpectomy, and it depends on the size of the tumor, where it's at in the breast. Is it multiple places or not? So everybody's not a candidate. And the size of your breast is important and what kind of cosmetic result you would get if they did a lumpectomy. And then there's different types of mastectomies. Used to, they would do very radical things and they would take it all the way down to almost the bone. Of course, we're not doing
We
quite
don't
the,
do that anymore.
don't do that anymore. But there are different kinds. And prophylactic, what is a prophylactic mastectomy?
Other breasts removed.
If you have genetic testing and you find out that you're a high risk for breast cancer, you might have a prophylactic mastectomy.
You don't have cancer in the other breast, or you don't have breast cancer. Like Angelina Jolie.
Yeah.
She did not have breast cancer, but she had prophylactic bilateral mastectomy because she had that genetic mutation. And then reconstructive surgery is an option, and there's so many different, that's a whole lecture in itself when you talk about reconstructive surgery. There's so
So
many
you
different
have
things.
to talk to a plastic surgeon.
I have a question, so for, you got the cancer and you had a double mastectomy with the law that says you have to have reconstruction. What about if you have the gene, the BRCA1, the gene, is it the same thing or no?
I think so.
I think it would apply because you carry, I think what was it, 80%
Yeah,
chance you
you
would
have-
develop breast cancer over your
Or
lifetime?
ovarian cancer, so I
And
think it
ovarian.
pays for the mastectomy and for the hysterectomy, oophorectomy.
That's a good question. Okay, so as you're going to have your surgery, your doctors, your surgeons, and your oncologists are talking about your treatment plan. Everybody's treatment is not exactly the same when you have breast cancer.
So they look at these things when they're planning your treatment. They look at the size of your tumor. Are the margins clear? Did the surgeon get all the cancer, or are they close to the normal skin around the tumor? So they need to get clear margins if possible.
Were there any lymph nodes involved? Had cancer spread to the lymph nodes? If so, and how many lymph nodes?
They look at hormone receptors, which are, breast tissue has estrogen receptors and progesterone receptors on the outside of the cell. So that's normal. If you're ER positive, estrogen receptor positive, it just means there are too many. There are overexpressed estrogen and progesterone receptors. So they need to find a way to block the estrogen in your body, because that means your cancer fed off the estrogen in your body.
Even if you're postmenopausal, our body still produces estrogens, okay? And the HER2.
The HER2, that's a growth factor in your cell, and that can be normal too, but if it's overexpressed, they need to find a way to block that HER2. Now, some people don't have these receptors, but some people do. If they do, there are medications available that you can take to block the estrogen or the HER2 receptors.
Now, the HER2 is a targeted therapy, because that's a target on the outside of the cell. So if you overexpress a HER2 protein, then we would use something called Herceptin, and that targets just that receptor on the outside of the cell. And we were talking about target therapy.
And they're finding some more. There's a HER4, there are more, and they're finding out more and more about these targeted treatments as they're finding more about cancer cells.
So they kind of put breast cancer into some subtypes, and they're looking at, who's heard the term triple negative breast cancer before? Has anybody heard that? That means that it was estrogen receptor negative, progesterone receptor negative, and HER2 new negative.
And in
Okay.
those cases, those medications will not work because those receptors aren't there to respond to the medication.
Okay. So they're kind of grouped into several different subclasses, and that tells the oncologist a lot about how that specific cancer behaves. And so they kind of look at that when they're planning their treatment. All right, so it's also with your treatment plan, it's very personalized, and some of you may have even had or if you've had breast cancer and you're here, a test called Oncotype DX. Who's heard of Oncotype DX? Okay, so that's only been out for about 5 or 6 years.
5 or 6 years. It's a test that looks at your cancer's genetic makeup, not your genetic makeup, but the genetic makeup of your cancer, and it can predict on a low, medium, or high score of whether you'll benefit from chemotherapy. So that really helps your oncologist know whether to give you chemotherapy. You know, used to everybody got chemotherapy, but now this test helps them know whether or not you need chemotherapy.
It's really changing how we treat breast cancer, a lot.
Mammoprint is a similar test.
And then, of course, we do genetic testing on women if they are high risk for breast cancer, if they're looking at their family history. So we look at all these things. And so then, we don't just get chemotherapy, you may get radiation therapy. And there's 2 types.
There's external beam radiation, that's about 38 treatments. They have to do 2 simulations, and then you come back Monday through Friday, and you're here about 15 minutes. It's like an x-ray. You lay on a table, they build a cradle, and you come back for about 36 treatments. Or there's the internal beam radiation, where it's called mammocyte. They put a catheter into the area where your tumor was, and they put radiation seeds into that area. You do that twice a day. It's a 5-day treatment. Some women are candidates for that and some aren't. It depends on where the cancer was in your breast and how large it was.
So, and we just did a few little side effects of radiation are pretty minimal, some fatigue and some skin changes. And then, of course, the word nobody wants to hear, the first word they don't want to hear is breast cancer. The other word is they don't want to hear chemotherapy, do they? So, and we just kind of went through why you would be maybe a candidate for chemotherapy. And some women get chemo before they even go to surgery if they have a very large tumor. And some women get, and which means adjuvant chemotherapy is after surgery. And, you know, you don't have to go to a great big medical center to get access to clinical trials. We do all kinds of clinical trials here. So you can come right here. You can even Google, this is what I love. You can go on the website, Google breast cancer through the NCI, say I want to see if there's a trial for me, and you'll say how far do you want to drive, and they'll say, oh, you have Dr. Chotzi right here in Burlington, and you can drive 5 miles and you can get any access you need. It's pretty cool.
We have a lot of trials open, so if you are diagnosed with breast cancer, you may qualify for one of those clinical trials.
Okay, let's try speaking here.
Yeah.
All right, so this is really quick on side effects of chemotherapy. Really depends on the drugs that you're getting. The side effects depend on the drugs, but some of the common ones are
Bone marrow suppression. Now, Sheena and I have been here for over 20 years, so we've seen a big improvement on treating the side effects from chemotherapy. But bone marrow suppression, where your blood counts drop, it puts you at risk for infection, fatigue, bleeding. So those are things your doctor will monitor. Nausea, vomiting, diarrhea, mouth sores or sores in your GI tract, hair loss, and fatigue are all side effects from chemotherapy. I think hair loss for women is probably the most scary.
But you know, we have so many drugs now, supportive drugs to manage the side effects. If you're home with side effects and what we're giving you is not working, patients need to be calling us because we've got something else to try, okay? And then this is just hormone therapy. We talked about the tamoxifen. And then trastuzumab is a Herceptin, and that's for only if you're HER2 positive. And there's other drugs coming out, pertuzumab or Perjeta, and there's more and more, and there's clinical trials, and there's research, and there's more things and more things.
Some are for metastatic breast cancer for women that have to come back for treatment if their cancer has spread. So they really are doing a lot better on updating medications.
And this is just a few of the anti-hormonal drugs called tamoxifen, aromasin, and arimidex, and Femera, different kinds. And we want you to choose Good Health at Alamance Regional.